Good afternoon, everyone. On behalf of Education and Professional Development Committee, I'd like to welcome you all to today's webinar entitled Role of Remote Patient Monitoring in Chronic Obstructive Pulmonary Disease. We're thrilled to have Dr. Jaclyn Hess as our guest who will present. Dr. Jaclyn Hess received her Doctor of Pharmacy from Long Island University in 2016. She's an ambulatory care clinical pharmacy manager at Mount Sinai Health Partners. She's a board-certified specialist in pharmacotherapy and in advanced diabetes management. Jaclyn specializes in primary care, cardiology, and pulmonary. She supports the PGY2 residency program as a preceptor for research. Before we get started, I'd like to share a quick point. For those who have technological issues during the presentation, please use the chat option to communicate with the office. Every effort will be made to assist in resolution. For those who have questions that you'd like to direct to the speaker, please use the question box or chat option. The CE code for this program will be provided at the end of the program. Okay, and there it goes. And Dr. Hess, the floor is all yours.
Thank you, Jennifer. And thank you everyone for taking the time to join today. I'm very excited to speak with you about remote patient monitoring in COPD patients. So let's get started. I have no conflicts of interest to disclose. The objectives for today are to describe remote patient monitoring and its role in COPD. We'll review COPD burden, pathophysiology, assessment and management of stable COPD, as well as exacerbations. We'll also discuss the available technologies and monitoring parameters for COPD RPM. We'll assess the overall impact of RPM on healthcare costs, utilization, as well as patient outcomes and satisfaction and quality of life. And then we'll wrap up with applying what we learned to a patient case. So first, let's review remote patient monitoring. This is when we use a device to measure a patient's physiologic data, such as their blood pressure, oxygen levels, or weight. And then that data is transmitted electronically to a portal or integrated directly into the electronic medical record. And in this graphic, we see that a patient, for example, measures their weight, and that scale can either have Wi-Fi or be cellular enabled to allow it to transmit readings on its own, or it can be Bluetooth enabled to interact with an external phone, tablet, or data hub to transmit those readings through a cloud so that it can be viewed by the healthcare team either in a portal or directly in their chart. And then from that data, it can be programmed to trigger alerts based on out of range values. So RPM has been used in a multitude of cardiovascular, endocrine, and pulmonary conditions, and some of the general benefits have included reduced healthcare utilization and costs, as well as improved health outcomes. So next, let's review COPD. It's a major public health problem leading to increased morbidity and mortality, and it accounts for more than 3 million deaths yearly worldwide. The World Health Organization estimates that by 2030, COPD will be the third leading cause of death globally. Acute exacerbations lead to an accelerated decline in respiratory function and further progression of their condition. In the US, costs attributable to COPD are expected to rise over the next 20 years, with projected costs of about $40 billion per year. COPD itself has a significant social burden and is the second leading cause of reduced disability-adjusted life years. There are 3 pathological processes for COPD, including chronic bronchitis, obstructive bronchiolitis, and emphysema. Cigarette smoke and other irritants activate the macrophages in the respiratory tract, which then release the neutrophil chemotactic factors, including interleukin-8 and leukotriene B4. These cells then release proteases that break down the connective tissue in the lung parenchyma, resulting in emphysema, as well as stimulate mucus secretion. We also have the cytotoxic T cells that can be involved in alveolar wall destruction. So when we're assessing COPD, we look at a variety of factors, and first is their clinical presentation. So these patients typically present with dyspnea, chronic cough, sputum production, wheezing. Sometimes they'll have some chest tightness and fatigue. Some of these symptoms are consistent with other diagnoses, so we want to rule out other potential causes such as asthma, heart failure, bronchiectasis, TB. And once we do rule out these other causes, we'll confirm a diagnosis with the use of spirometry to help identify the existence of airflow obstruction and then determine its severity. So through this test, we're capturing the forced vital capacity and forced expiratory volume in 1 second to then assess the ratio and determine the airway obstruction, which is defined as an FEV1 over FVC of less than 0.7. And then another aspect that we look at is the patient-reported symptom assessment. So there are multiple options available. With the MMRC, it is known to measure breathlessness, and the scoring relates well to some of the other multidimensional health status measures and predicts future mortality risk. With regards to the CRQ and the SGRQ, these are more comprehensive disease-specific health status questionnaires. They're very complex and consist of between 20 to 40 plus questions each, so they're not typically utilized on a regular basis. And then the CCQ and the CAT assessments are shorter, comprehensive options that we typically see being utilized more routinely. So once we have a diagnosis, we then want to classify the severity through the GOLD grading system based on the FEV1 % predicted. After we understand that severity, we're looking at their symptoms and their risk for exacerbations to then determine their COPD group and further recommendations on management. So for our patients with a low symptom burden and low risk for exacerbations, they're classified as Group A. With patients who have a higher symptom burden, but still a low risk of exacerbations, they would be classified as Group B. And what's new in the 2023 guidelines is that they have merged the prior Group C and D to form a Group E in order to highlight the clinical relevance of exacerbations, regardless of what the patient's symptom burden is. So non-pharmacologic management is vital in these patients. Smoking cessation, physical activity, and vaccinations are recommended for all patients across the board. For those patients with a higher symptom burden or high risk for exacerbations, regardless of their symptom burden, pulmonary rehab is another consideration. And just to do a deeper dive into some of the additional non-pharmacologic options for these patients, it's really important to ensure that patients have this education and some guidance on self-managing their condition in order to help motivate them, keep them engaged, and allow them to help positively adapt some of these healthier behaviors so that they know what to do in certain scenarios and to help navigate their symptoms and management without having to necessarily seek the emergency room or the hospital. With regards to physical activity, most of these patients over time become less active, and that predisposes them to reduced quality of life, and they typically then have increased hospitalizations and mortality. As mentioned, pulmonary rehab can be highly beneficial in some of our higher risk patients, especially post-discharge from an exacerbation. And then we want patients to be active with regards to interval and strength training, and then utilizing pursed lip and diaphragmatic breathing can help improve pulmonary function and then increase their exercise capacity over time. It's also important to make sure that these patients have advanced directives in place, so working closely with them and their families to ensure that their care plan is consistent with the patient's values. As COPD progresses, weight loss and malnutrition typically develop, and it indicates a poor prognosis. We know that malnutrition is associated with impaired lung function, increased hospitalizations and mortality, poor exercise tolerance, and worsened quality of life. So providing dietary education that includes oral supplements has been shown to improve body weight, quality of life, improve their respiratory muscle strength, and their 6-minute walking distance. In certain cases, as listed on the slide, oxygen can be useful. And then we also want to consider ventilatory support for patients with daytime hypercapnia, as well as those who also have concurrent obstructive sleep apnea. So next we'll go into the pharmacologic management for COPD. And on each slide, I've listed the available agents for each class, as well as some additional information for completeness sake. Our bronchodilators are central for the management of COPD to help improve symptoms, and they're typically given on a regular basis. Our beta-2 agonists reduce dynamic hyperinflation at rest and during exercise to improve performance, along with improving FEV1. As for our short-acting agents, when they are used regularly during an acute exacerbation or as needed, they typically lead to an improvement in some of their symptoms and overall FEV1 over time. And then the long-acting agents significantly improve lung function, dyspnea, health status, and reduce exacerbations. As for our antimuscarinics, the short-acting agents have provided small benefits over SABAs in terms of lung function, health status, and requiring oral steroids. However, when these are combined as SABA-SAMAs, it has been shown to be superior to either alone in improving FEV1 and symptoms. As for the long-acting agents, LAMAs have a greater effect on exacerbation reduction when compared to LABAs, as well as a reduction in hospitalizations, but we see that effect to a larger extent when they're combined together. And that further leads to an improvement in their symptoms, FEV1, lung function, and overall reducing their exacerbations. Next, we have our inhaled corticosteroids. Alone, these agents do not modify long-term decline in FEV1 or mortality. When they're combined with long-acting bronchodilators for moderate to very severe COPD, triple therapy was found to be more effective in improving lung function, symptoms, and health status, as well as reducing exacerbations when it was compared to different modalities. So combination LABA plus ICS, dual bronchodilators, or LAMA monotherapy. And latest data has suggested a benefit from triple therapy compared to dual bronchodilators on mortality in symptomatic patients who have a history of frequent and/or severe exacerbations. And then with regards to these agents, the blood eosinophil count can predict the magnitude of effect from utilizing these and preventing future exacerbations. And that's why this class is recommended if the eosinophil count is at least 300 cells per microliter. So next we have our methylxanthines, and we don't typically see these used commonly in these patients, but they do have a modest bronchodilator effect compared to placebo in stable COPD. And in one study, when they were added to salmeterol, there was a greater improvement in FEV1 and breathlessness. There is some conflicting evidence on how these agents do with regards to exacerbation rates, another reason why they're not typically seen as often anymore. Next, we have our phosphodiesterase 4 inhibitor, roflumilast, which has been shown to reduce moderate and severe exacerbations in patients with chronic bronchitis, severe to very severe COPD, and a history of exacerbations. An improvement in lung function was noted when it was added to long-acting bronchodilators and when controlled on fixed dose combination LABA with an ICS. And that benefit was seen predominantly in patients who were hospitalized for an exacerbation. With regards to the mucolytics, also other agents that we don't typically see as often, in a small subgroup of patients who are not on inhaled corticosteroids, these can potentially reduce exacerbations and modestly improve health status. And lastly, our glucocorticoids are utilized for exacerbations and can reduce the rate of treatment failure, relapse, and improve lung function and symptoms. We want to be mindful in very severe COPD for the risk of steroid-induced myopathy, which can contribute to muscle weakness, reduced functionality, and respiratory failure, which ultimately worsens the patient's condition. As for our antibiotics, there are multiple classes that can be used. So we typically see our macrolides, tetracyclines, and penicillins. Some of the older studies showed that prophylactic antibiotics had no effect on the frequency of exacerbations, whereas later studies have showed regular use of certain antibiotics can be used to help reduce exacerbation rates. And a lot of that evidence supports the macrolides. So for patients who are more prone to exacerbations, using a macrolide daily or 3 times a week for 1 year was shown to help reduce the risk of exacerbations. And they did note that this was to a lesser effect in active smokers, which is why we typically don't utilize it in that population. And then just to note that there is no data to support the use of these agents beyond 1 year. The main time that we'll see antibiotics coming on board outside of our higher risk patients is during those exacerbations. So if patients have any signs of infection, they have the 3 cardinal signs, so increased dyspnea, increased sputum volume, or increased sputum purulence. They can have either all 3 or at least 2, with 1 being sputum purulence. That's when we want to consider adding these agents on, because they've been shown to shorten the recovery time for the patient, reduce the risk of relapse, treatment failure, and hospitalization. And when we are utilizing these agents for an exacerbation, they shouldn't exceed 5 days worth. So when we have a patient with stable COPD and we're looking to initiate pharmacotherapy, we go based on their treatment group. So for those patients in group A with a lower symptom burden and low risk of exacerbations, we're looking to start either a short or long-acting bronchodilator. A long-acting agent is preferred if it's available and affordable for the patient, except when the patient has very occasional breathlessness, then it's reasonable to start with a short-acting agent. As for our patients in group B, so they have a higher symptom burden, still fairly low risk with exacerbations, we want to start therapy with a combination LABA/LAMA. And that was because when combined, it was shown to be superior to either component alone. If for whatever reason that combination is not appropriate for the patient, then there's no evidence to support using one class over the other. So either one can be chosen. For group E patients, those are our more high-risk patients due to their risk of exacerbations, regardless of their symptom burden. Initial therapy should consist of combination LABA/LAMA. For certain patients where their eosinophil count is at least 300 cells per microliter, or they have another indication such as underlying asthma and would benefit from the use of an inhaled corticosteroid, then triple therapy was shown to be superior to alternatives. So LABA plus an ICS or dual bronchodilator therapy. So once we initiate these medications, it's very important for us to have continuous follow-up with the patient just to assess that they are meeting their treatment goals. They're not necessarily having any flares in their symptoms, and then identifying if there's any barriers for success to them controlling their condition. So it could lead to potential inhaler technique issues, whether or not it's the appropriate device that they're utilizing, or possibly switching between different medications itself, addressing any non-pharmacologic options that are still available and the patient is interested in, and then potential options to de-escalate depending on the situation. And the guidelines recommend different recommendations for if the patient continues to have dyspnea or if they continue to exacerbate. So for those patients with continued dyspnea, if they're already on a single bronchodilator, they should then be transitioned to combination LABA/LAMA. And then if that dyspnea continues to persist, it's really looking into whether or not the device that they're using is appropriate for what they're able to use. If they're utilizing the correct technique, possibly switching between different medications, and then looking at those non-pharmacologic options, and then other causes for the shortness of breath. If patients continue to exacerbate and they were on a single bronchodilator, if their eosinophil count is less than 300, then we want to transition them to dual bronchodilator. If it was at least 300 or greater, then they would be transitioned to triple therapy. If on dual bronchodilator and they have an eosinophil count between 100 to 300, then we can consider adding the inhaled corticosteroid. Then for patients who are treated with triple therapy or dual bronchodilator without an eosinophilia, but they're still exacerbating, that's when we want to consider some of the last line options. So adding roflumilast if the patient has an FEV1 of less than 50% and they have chronic bronchitis, especially if they had a recent hospitalization in the past year for COPD. We can consider adding a macrolide with the best evidence for Zithromax, especially in those who are not current smokers. And then our other option is stopping the inhaled corticosteroid. And this can be considered if the patient is having adverse effects. So if they're having recurrent pneumonia, this may be an option that we want to consider, or if they're not improving with the addition of it. But we do want to keep in mind that those patients with an eosinophil count of at least 300 do have the greatest likelihood of experiencing more exacerbations after we stop the ICS. So they'd have to be followed very closely for a relapse of their exacerbations. When we're managing exacerbations, and this is predominantly for the outpatient setting, we want to assess the severity of symptoms to determine the appropriate setting to manage the patient. So if we can continue working with them outpatient, a lot of these steps is what we will be taking. And then if not, then we will be advising to go to the emergency room for evaluation on whether or not they need to be hospitalized, with some of these recommendations aligning. So for patients who are hypoxic, if supplemental oxygen is available, then they should be advised to utilize it. For short-acting bronchodilators, we like to combine both SABAs and SAMAs, and then we want to increase the dose and/or frequency of administration. And when appropriate, recommend the use of spacers if patients were previously using them, or nebulizer machines, to make sure that they're getting their full dose. And then once patients are stable, making sure that they're started back on their long-acting agents, or started initially on long-acting agents if they were never on before. As for our oral steroids, we want to consider incorporating these into the mix if the patient's breathlessness is interfering with their daily activities. And then for antibiotics, as I mentioned earlier, if they have signs of a bacterial infection with the consideration of those cardinal signs, we can utilize them at this point. And then at all times, we want to make sure that patients are maintaining hydration and managing any other conditions that may be acting up in concurrency. So once the patient has this acute flare, whether or not they're hospitalized, we do want to make sure that we're having a close follow-up with them for the first 3 to 4 months, since it can take patients that long to fully get back to their baseline prior to the exacerbation. So typically we want to make sure that they're seen in the office at 1 to 4 weeks, and then again 12 to 6 weeks after the acute event. And during these visits, we want to be evaluating the patient's ability to get back into their usual routine. We want to double check their treatment regimen to make sure that it's appropriate and that they're able to utilize their inhalers correctly. And then if patients were started on long-term oxygen or we had them utilizing their oxygen more routinely, we want to reassess whether or not they need to continue. At each point, we want to identify what their exercise capacity is and always consider a referral to pulmonary rehab if possible. Also looking at the improvement of their symptoms, since a lot of their symptoms will typically take a while to fully subside. Usually the biggest complaint is that their phlegm is not necessarily going away as quickly as they'd like it to. And then also determining what the status is of any of their other comorbidities. And then at that later touch point, we want to make sure that they're improving in the sense of being able to perform some of their activities of daily living, as well as check their spirometry. So next, we'll look into the role of RPM in COPD. And why is it important for us to manage COPD and the exacerbations in a timely manner? So we know that it comes at a cost for both the patient and the healthcare system. We see increased mortality, a reduction in quality of life, the economic burden that it has for both parties, higher rates of readmissions, and then patients also experience an increased absence from work and reduced productivity. So overall, it's a negative experience if they're frequently and having more severe exacerbations. So when we're thinking about managing a patient with COPD through remote monitoring, in addition to those physiologic parameters, we're also interested in their symptoms, medication use patterns, and some external factors. So for physiologic monitoring, we want to consider collecting their oxygen saturation, respiratory rate, pulse, activity, pulmonary function tests, and there are a multitude of device options available. They can include a spirometer, pulse ox, and then there's continuous monitoring devices. In addition, we can leverage digital engagement tools through the use of a tablet or a smartphone to help capture symptoms as well as medication use patterns. And then there are passive monitoring devices available that can be utilized to assess medication usage, such as counters to be placed on inhalers, as well as sensors for external factors. And those environmental sensors would allow us to kind of get an idea of what the patient's being exposed to every day. They're typically placed around the house and kind of help us identify if there's any exposure to pollution, temperature changes, circulating viruses. That way the patient is aware of what's actually happening around them to help try and modify their risk to any triggers that can lead to an exacerbation. And then studies have shown that when you're incorporating some of these other items in addition to the physiologic parameters, it allows us to get a more detailed picture of COPD and the day-to-day fluctuations that patients experience. So remote patient monitoring, as we know, has shown large impacts in the management of many chronic conditions. However, with COPD, the heterogeneity and lack of objective signs of exacerbations make it a little difficult or challenging to use an RPM in this population. So there are many studies out there that have used various methods of RPM technologies, different physiologic parameters that they collected, alerting systems, and as a result, we see both positive and negative outcomes. So when evaluating patient-specific outcomes, there have been some studies that show a reduction in symptoms and improved quality of life. We do see that in this population, it's critical to ensure that patients are able to adapt the skills to better self-manage their condition. And right now, there's no standard procedure or recommendation for the development of these self-management skill programs. So there's limited data available assessing the effects of these programs on patient outcomes. COPD itself is both physically and psychologically disabling. Depression and anxiety have a high prevalence in this population, and a small portion of these patients seek and receive treatment for their condition. So with RPM, it allows that additional touch point with the care team to help identify any changes in their mental state, discuss other common comorbidities, and refer to specialists for further management as needed. And studies have shown that when patients had an increased awareness and understanding of their condition, they had those more frequent touch points with the medical team, and it allowed for more quicker assessment and treatment of their conditions, that they had an improvement in their quality of life and a higher overall satisfaction. With regards to the economic burden, their costs increase depending on the severity and frequency of exacerbation, and the data on healthcare utilization and cost savings utilizing RPM in this population is limited. Some studies have shown a reduction in ED visits and hospitalizations, while other studies have refuted this. And there have been widely variable projections on the cost reduction seen for these patients, and that ranged anywhere from $700 to more than $4,000 per patient per year. So first, we have the telemonitoring and COPD CROMED study, which was a multi-center randomized unblinded parallel group trial that took place in Europe. So patients received this continuous wearable wristband along with what was a CROMED monitoring platform, which included a touchscreen computer and a mobile modem. And some patients also had concurrent heart failure, so they received a separate device that would pick up additional vitals so that they can differentiate between which symptoms or potential exacerbation the patient was having. They developed an algorithm to generate alerts if the patient's respiratory function was worsening, having a worsening trend, and then patients were outreached based on alerts and every 2 to 3 months. Their primary outcome was the time to first hospitalization and the change in EQ 50 utility index score, which is a European quality of life questionnaire. Their secondary outcomes included the rate of moderate exacerbations, hospitalizations and rehospitalizations, length of stay, and final score of the CAT and PHQ-9 questionnaire. They also performed a cost utility analysis to compare healthcare costs and quality adjusted life years. And they found that 48% of patients in the intervention group were hospitalized and had an alert generated within the 2 weeks prior to the event. The time to first hospitalization was a mean of 224 days in the intervention group compared to 254 days in control. There was a higher incidence of rehospitalizations in the control group, and they found that there was no significant difference between groups with regards to any of the questionnaires. So the quality of life questionnaire, CAT assessment, and the PHQ-9. They had concluded that the patients in the intervention group had a more than 50% reduction in rehospitalizations and exacerbations. And they noted that when they combined the symptom assessments with physiologic data, it helped them identify the exacerbations better. And then their cost utility analysis found an average cost savings of about $1,900 per patient year based on UK healthcare costs. Then we have Koff et al., who performed a prospective quasi-randomized clinical trial across multiple clinics in Colorado. And these patients were randomized to either usual care or to participate in a 9-month disease management program. And that consisted of remote monitoring, education, symptom assessments, spirometry, a pulse ox, 6-minute walking test, and quality of life assessments. And then they generated alerts based on changes in any of these components. The primary outcome was healthcare costs, and then their secondary outcomes were quality of life, respiratory symptoms, healthcare utilization, and their 6-minute walking time. And what they found was that the structured disease management program, along with patient monitoring, helped reduce COPD-related urgent care visits by 76 visits per patient, 100 patients, and non-significantly reduced COPD-related ED visits. They found an average cost savings of more than $4,000 per patient per year. They also found statistically significant improvements in the SGRQ score at 3, 6, and 9 months when compared to usual care. And then they noted that in the intervention group, patients were more likely to report less smoking, cough, sputum, breathlessness, and an improvement in their post-exercise oxygen levels. And they were also able to walk further during their 6-minute walking test. Lastly, I wanted to go over a more recent study that came out earlier this year by Polsky et al. And they retrospectively analyzed patients pre and post initiation of remote patient monitoring between May 2019 through February of 2022. Through RPM, patients received a sensor device that would attach to their undergarments. They also had a data hub and they had access to a web dashboard. So they had collected the patient's pulse, their continuous respiratory force and activity. And then alerts were generated based on a % change over rolling baselines, along with any individual critical readings. Once an alert was generated, patients would receive a call within 24 to 48 hours to assess symptoms, and if needed, they were scheduled for an in-office visit. Their primary outcome was unplanned all-cause hospitalizations, and then their secondary outcomes were unplanned cardiopulmonary hospitalizations, ED visits, length of stay, outpatient pulmonary visits, steroid use, and then any RPM utilization. So they found a reduction in overall number of hospitalizations and ED visits, both for all-cause and for cardiopulmonary indications. And when broken down per patient, these reductions were statistically significant. And then, although not significant, there was a shorter length of stay post the initiation of RPM. They did note that there was an increase in the number of outpatient office visits and steroid use, as opposed to us seeing, in response to us seeing that change in hospitalizations and ED visits. And then as for RPM utilization, adherence for most patients was at least 90% of the 12-month period. And they did note that adherence waned over time, which we typically see throughout RPM. And then with regards to those escalations, RPM resulted in 52 additional office visits, and patients were typically seen within 2 to 3 days. So when we're considering enrolling patients into remote monitoring, we want to make sure that they're set up for success and understand the barriers that potentially come up with it. So looking into what can interfere with the patient adhering to program requirements, so what health and technology literacy is needed in order for them to utilize the device. Do they need any additional resources, a smartphone, Wi-Fi, etc.? So when we looked into the literature, we knew the impact that COPD has worldwide, and then that expected rise in cases, as well as the burdens put on for future years. We know that these exacerbations result in a reduction in quality of life, economic burden, and greater mortality. And remote patient monitoring could potentially help detect exacerbations early, resulting in more timely management and a reduction in healthcare utilization and costs. And there are numerous devices available, but we want to make sure to incorporate additional data in addition to the physiologic parameters to ensure that we get better outcomes. And then understanding our target population is important to help reduce any potential barriers and ensure the patient is successful in taking advantage of the RPM program. So lastly, we'll look at how to manage a patient with COPD through the use of RPM. And before getting into our patient case, I wanted to review some of the items that we focus on in our visits, as well as give a little background to our program at Mount Sinai. Our patients receive either a continuous wearable device that's worn on the upper arm or an intermittent pulse ox. And in addition to this, they receive a tablet where they can access their care plan, education on their condition. They can attend any video visits with the team and complete symptom surveys. Throughout our visits, there's a heavy focus on completing a med rec, assessing any comorbidities, COPD history, their vaccination history. We look at their symptoms along with their physiologic parameters, so identifying what their goals are, what their trend is, and ensuring that they're well understood about where their level should be at. We also review their medication, so looking for opportunities to maximize their regimen if needed, their oxygen supplementation, and then any non-invasive ventilation that's required. And we're assessing for adherence, barriers to use, side effects, any inhaler technique issues, and then how often they're utilizing some of these things. And then there's a huge focus on lifestyle and self-management, so addressing smoking cessation if it's indicated, identifying triggers and ways to avoid exposure, any stress and anxiety management, and then diet and exercise. And then in the initial visit, we wrap up with creating a COPD action plan that's reviewed at each follow-up visit, just to ensure that patients have the tools that they need to guide any decisions on what to do when their symptoms change in between our visits. And then in addition to optimizing their status during stable COPD, we're also helping manage exacerbations. So once we identify any changes in their symptoms, or there's changes in their vitals and that's confirmed with the patient that they're not doing as well as they usually are, then we're working with them to start them on a plan with managing the exacerbation. So let's meet MH. She is a 55-year-old female with a past medical history of asthma and COPD overlap. She has OSA, hypertension, and depression. She's a current everyday smoker and social drinker. As for her exacerbation history, she was hospitalized for COPD in May of 2022, and at that time felt chest tightness and shortness of breath, which is typical for when she has flares. She is not actively on oxygen supplementation or non-invasive ventilation. Her blood eosinophil count earlier that year was 300, and her latest PFTs at that time showed an FEV1 of 37%. She was enrolled in remote patient monitoring on August 31st of last year. As for her active medications at that time, she had albuterol nebulizers and inhalers as needed for shortness of breath. She was on Symbicort twice a day, Singulair, Daliresp once a day, and then also on Spiriva. And then for her comorbidities, she was on Lexapro, Losartan, and nifedipine. As for her vaccination history, she had the influenza vaccine in 2021. She was up to date with COVID, Shingrix, and Tdap, as well as the pneumonia vaccine, considering her age. So we're now going to go into a polling session to see what we have learned for today. Based on MH's FEV1 of 37%, what gold grade would she be classified as? The correct answer is gold grade 3, and that's based on the FEV1 of 80% plus would be gold grade 1, 50 to 79 is gold grade 2, 30 to 59 to 49 is grade 3, and then less than 30 is grade 4. So our next question What next steps for managing MH should be considered? And this is select all that apply. So do we want to discuss smoking cessation and assess her willingness to quit, recommend an influenza vaccine, maximize her regimen, or start an antibiotic based on the information that we currently have? So the correct answers are A and B, with potential consideration for C. Since she is an active smoker, we want to discuss smoking cessation, and if interested, make sure she's set up for success. It was flu season at the time that she was enrolled in the program, and her last vaccine was from 2021. So we do want to recommend that she receive that vaccination at that point. With regards to her therapy, she is fairly maximized with regards to COPD. She was on triple therapy and roflumilast. Because she is an active smoker, there's less consideration with us wanting to start Zithromax. And then with regards to starting any antibiotic for another indication, such as the exacerbation, we don't know that she's actively having one at this time based on the information that we have available to us. So yes, good job. So just to go through her course in remote monitoring during this time. So she had her initial visit with me on September 26th, where we completed a med-rec. She reported 100% adherence and then went through the steps of appropriate technique for each of her inhalers. We discussed the exacerbation triggers. A lot of them she was unaware of, so it was a very useful conversation to highlight a lot of the items that typically could make her symptoms worse, and she didn't identify that cigarette smoking was something that would worsen it. So it was good for her to get a better understanding of some of those trigger points. And then we also discussed lifestyle, so her diet, exercise, and smoking cessation, which she had reported side effects from NRT and was not necessarily interested in any assistance at this point in time. As seen on the right, her vitals were stable. With O2 in the mid 90s, her heart rate in the 70s, respiratory rate is 20, and then her skin temperature was appropriate for the upper arm where the device is placed, and then she had an average activity level. So for her next steps, we recommended she receive the flu vaccine, avoid any known triggers for exacerbation. We encouraged exercise and reinforced the benefits of smoking cessation. And then she had identified that she was interested in weight loss. So I transitioned to her to co-management to work with our dietitian. I followed up with her on October 20th due to alerts for hypoxia that lasted for more than 5 hours. And her oxygen level throughout this time were in the mid 80s. She was using her maintenance regimen and reported only using albuterol less than 3 times a week. She had some weakness and low energy, was feeling more tired, had dyspnea on exertion. Her cough was worsened, and she was having some chest tightness on ambulation that was slightly worse from her baseline. She did note that she was smoking more cigarettes than previously reported, and she noticed a reduction in her ability to ambulate before becoming more short of breath. So I had spoken with her provider, and we started her on a prednisone course with albuterol every 6 hours around the clock. And then she was scheduled to follow up in the office 1 week later. Again, reiterating with her to reduce smoking and any exposure to additional triggers. On the 26th, I spoke with her. There were no alerts between that time frame. She completed the prednisone course, however, identified that she was not utilizing albuterol as instructed and had only used it 3 times since we last spoke. She did notice improvement in her symptoms and had not cut back on cigarettes between that time frame. Actually continues smoking the same amount roughly for the duration of her enrollment. And then in the office, when she was seen by the pulmonologist, she did start using the albuterol after we spoke. So she used it twice the day before and then once that morning. They did a 6-minute walking test and she desatted to 87% on room air. And then they had to stop it early because she developed chest tightness. She also had a sleep study performed that revealed mild OSA. So as for next steps, she was prescribed budesonide nebulizers twice a day for at least a week with follow-up from me a week later. And then she was also started on 1 liter nasal cannula as needed for activity and prescribed CPAP. And then of course, educating to continue to reduce smoking. On November 4th, we had gotten an alert for hypoxia where her oxygen was in the mid to high 70s and her heart rate was running between 34 and 58. She reported that she was using her maintenance medications, but had stopped using the albuterol and never picked up the budesonide nebulizers. She refused to use the oxygen because it was drying out her nose. During our call, she was actively trying to catch her breath, continued to have the dry cough, chest tightness, noted that she had subjective fevers and an itchy throat. And at this time, I had asked her to put the oxygen on, give herself an albuterol nebulizer treatment, and to repeat that in 15 minutes if symptoms didn't improve. And then concurrently, I was messaging with her provider and we decided to activate our hospital paramedic program because the patient was refusing to go to the emergency room. However, our paramedic program decided that it was more appropriate for her to get evaluated sooner. So after a little bit of convincing, the patient was agreeable for having me call 911 and having EMS come and evaluate her. They did end up not taking her to the hospital. Her O2 sats did eventually come up to the 90s on 1 liter of nasal cannula. And when the physician had reached out later that night, she had started her on a course of Zithromax, ordered a chest x-ray for the following week, and stressed the need to pick up and start the budesonide nebulizers. And then I spoke with her next on November 9th. She had periodic alerts throughout the day for hypoxia, but they didn't continue to persist beyond that. She had completed the Zithromax the day before and confirmed that she did begin using the budesonide nebulizers a day or two after the event before. And then her oxygen she was using at bedtime and during activity. She did stop using albuterol as frequently as we were telling her to. Her symptoms did improve and her chest x-ray was clear. And then again, her cigarette usage was reportedly the same throughout this entire time. I had then spoke to her again on November 23rd, and between these visits, she didn't have any alerts for hypoxia or any changes to her other vitals. She did report adherence to her maintenance regimen, and she was using albuterol as needed. She noted continued improvement in her symptoms and ability to walk a little bit further each time. As for her next steps, we again had a very lengthy discussion about smoking cessation and the impact of cigarette smoke on worsening her symptoms. She continued to remain uninterested. So the recommendation was just to continue trying to cut back and avoiding additional triggers. And then she was to use the oxygen as needed and at bedtime until she received the CPAP machine. In conclusion, remote patient monitoring allows for additional data to enhance visits, help detect exacerbations earlier, and allow for more timely treatment to ultimately reduce healthcare utilization and cost. We want to look at not only physiologic parameters, but symptoms as well as medication use patterns to give us a better idea of the overall patient and better outcomes. And then providing daily education and frequent interactions with the team can help the patient better understand their condition, keep them engaged with the program, and then ultimately improve their self-management skills. These are my references. I thank everyone for their time. Do you have any questions?
Thank you very much, Dr. Hess, for providing today's webinar. There is actually one question in our session. So, hi, thanks for excellent COPD review. What is the latest data on using Symbicort versus albuterol for acute exacerbation?
So for COPD, they're still recommending albuterol, short-acting beta agonist with SAMAs if available. For asthma, that's when we're typically seeing the Symbicort being utilized more often than albuterol for the acute exacerbations.
Great. Anyone have any other questions for Dr. Hess? Okay, I guess I have one question. So based on your experience, which remote monitoring device have worked the best or worst? I know you talked about there's some using wristbands or finger pulse oximeters. Are there anyone that's most commonly used?
So a lot of the studies were using pulse ox devices. Because of the mix of data that was available result-wise and a lot of the conflicting evidence from there, it was a lot more people are looking into continuous devices. So that's something that we started our program out with and have had success so far. But we also utilize the intermittent in addition to that. I think the biggest takeaway with the devices is just ensuring that you also incorporate some of the other parameters to kind of gauge what else is going on with the patient so that you have a better understanding what the symptoms are changing, if they're actually using their medications. For this patient, for example, if she had repeatedly told me that she wasn't using the albuterol correctly, so it gives you the idea that she probably wasn't using some of her other medications as often as she was saying. So some of those other options could have been a little bit more useful to also incorporate in to get a better understanding.
Great, thanks. We'll just take one more question. So are payers recognizing COPD as a disease state for which remote patient monitoring services are reimbursable?
So they are, I'm sorry, you said which payers, Jennifer?
Yes.
Okay.
Yes.
So Medicare covers right now 80%, and then typically patients have a 20% co-share. But if they have a secondary insurance, most of the time it is picked up. Health First Medicaid also covers RPM services. 1199 does. For COPD specifically, World Trade Center insurance also covers. And then there's a few other ones, not fully familiar with the exact names. 32BJ is an insurance that also covers, but most of our patients are typically Health First Medicaid or Medicare with another form of Medicaid that covers.
Great, that's actually a lot than I thought. So I will actually speak of CE code now. So the recording can be stopped.